I'm Lisa Villanueva. I'm a cardiologist from the University of Pittsburgh and the director of the Center for Ultrasound Molecular Imaging and Therapeutics at the University of Pittsburgh Medical Center. I will be talking about the principles of molecular imaging using ultrasound contrast. Diagnostic imaging in medicine has evolved over decades to first start off with anatomic definition using imaging, to functional imaging such as with stress testing, and more recently to the interrogation of tissue at the molecular level, such as shown here on a biopsy or a PET image showing estrogen receptors. So we've been able to make considerable progress in our ability to image from the whole body or whole organ level to physiology and now to molecular imaging. The definition of molecular imaging is a non-invasive visualization, characterization, and measurement of biological processes at the molecular and cellular level in humans and in other living systems. This shows a schematic of some of the prerequisites to in vivo molecular imaging. First, this is a cell, and you have targets. These are the things that you want to image. And this can be an extracellular protein like a transmembrane receptor, cytoplasmic protein or structure, or something in the nucleus. Then you have a targeting ligand which attaches specifically to the target of interest. And this targeting ligand is coupled to a probe that can be detected using an imaging strategy. It could be a nuclear probe, or in our case, an ultrasound probe, such as a microbubble. Molecular imaging research involves identifying targets, then identifying suitable ligands, and then testing these in appropriate in vitro and in vivo models, optimizing the imaging systems, and finally assessing the coupling of the molecular probe with the imaging system. This is just a partial list of molecular imaging targets. This could include metabolism, blood flow, receptors, the expression of transgenes, autonomic innervation, hypoxia, angiogenesis, inflammation, cell proliferation, apoptosis, or the trafficking of therapeutically delivered cells. Now, the targeting ligands, or the molecular probes, are what confers specificity to the target. These can be antibodies that are attached to an imaging probe, or the naturally occurring ligand for receptors such as estradiol, testosterone, or vascular endothelial growth factor. The targeting ligand could be a peptide or a small molecule, or an aptamer. The concept of ultrasound molecular imaging is shown on this slide. This is a schematic of an endothelial cell membrane which is expressing some sort of a disease marker such as a leukocyte adhesion molecule, as occurs in early atherosclerosis or heart transplant rejection or other inflammatory states. A regular microbubble has nothing on the surface and will transit through the microcirculation unimpeded. However, a targeted microbubble bears a targeting ligand on its surface, such as a monoclonal antibody, which causes it to bind or to adhere specifically to this disease marker. And during ultrasound imaging, this will manifest as a persistent contrast effect as opposed to a transient contrast effect, which would occur when a microbubble just transits through the microcirculation. Because the ultrasound contrast agents or microbubbles are exclusively intravascular in location, the targets that we have for molecular imaging with ultrasound are endoluminal, they're function specific, and it's required that they have low constitutive expression, and it should be present in the microcirculation, because as I mentioned, the microbubbles are intravascular in location. What about the targeting ligand? Of course, it must be specific for the endothelial target. It must have high affinity for the target, form a strong bond, and it must be able to be attached to the bubble in sufficient numbers to maximize binding. There's differing formulations of the targeting ligand. As I mentioned, antibodies have been used predominantly for proof of concept studies, and these have high specificity, strong bonding. They're large molecules, but the disadvantage is that they're immunogenic, which limits the human application of antibodies for targeting ligands. Peptides are good because they're small and non-immunogenic, and lots of it can be attached to the bubble, but the specificity and binding could be less. And then another strategy for targeting ligand is to use a naturally occurring ligand, which has high specificity and is non-immunogenic. What about the requirements for the microbubble itself? The microbubble must be stable during in vivo circulation. That means it must remain acoustically active while circulating, and also once it's bound to the target. It must present the targeting ligand optimally to the endothelial surface. That means that the orientation of the targeting ligand must be such that it will cause the bubble to bind to the active site of the target, and often the spacer arm is required to optimize the binding kinetics. What is the ideal targeted microbubble? Well, the ideal bubble should bind quickly and strongly to the target. It must remain acoustically active once it's bound. It must bind in proportion to the magnitude of target expression, and that way it can detect a range of disease severity. The microbubble should be detectable as a signal that's distinct from freely circulating microbubbles, which constitute noise. So therefore, typically when we do molecular imaging, we image after the unbound bubbles have dissipated in order to detect a signal that's specific for a bound bubble. Some of the potential clinical applications of molecular imaging using ultrasound are shown on this slide. Because microbubbles are intravascular agents, we can use them to characterize endothelial phenotype, such as cardiovascular diseases associated with endothelial dysfunction or inflammation, or markers of neovascularization or angiogenesis. Some of the clinical applications include early detection of disease, such as early atherosclerosis, follow-up of treatment using molecular markers as surrogate endpoints for assessing response to therapies, and targeted imaging and delivery of therapeutic agents using ultrasound-induced microbubble destruction, or so-called theranostics. What I'm going to do is just review some of the data that have been reported on molecular imaging with ultrasound in the realm of inflammatory imaging and in the detection of angiogenesis. The initial studies for molecular imaging with ultrasound were based on the concept of a leukocyte binding to inflamed endothelium. This is a schematic of a leukocyte and an activated or inflamed endothelial cell that is overexpressing leukocyte adhesion molecules such as E-Selectin, P-Selectin, VCAM, and ICAM. Through interactions between the leukocytes, ligands, and these receptors on the endothelial cell, a leukocyte is led to tether, then slow down, roll, and then firm adhesion. The tethering and rolling is mediated by the Selectin family of leukocyte adhesion molecules, and firm adhesion is mediated by ICAM. This is a intravital microscopic image of an inflamed venule in rat cremaster muscle. And as you can see here, these are individual leukocytes that are slowing down, rolling, and firmly adhering eventually. Here's a rolling leukocyte here. And these interactions that slow these cells down are mediated by these leukocyte adhesion molecules. And so the idea was to design a microbubble that would behave like these leukocytes and slow down and bind to leukocyte adhesion molecules in the microcirculation. What we initially chose to do when we first started doing this work is to target the adhesion molecule ICAM1, intercellular adhesion molecule 1, because this molecule is overexpressed in early atherosclerotic lesions. So this is a rat aorta. This is an aorta from an ApoE deficient mouse showing early fatty streaks, and you can see that there's co-localization of ICAM1 in the area with early atherosclerotic lesions. So what we decided to do is make a lipid microbubble that bears a monoclonal antibody directed against ICAM1 on its surface. And this is a approximately 3 micron bubble that we conjugated an antibody to the shell using biotin-avidin bridging chemistry. So we came in with a strep-avidin, which attached to the biotin on the microbubble shell. And then we took a biotin-related anti-ICAM monoclonal antibody and bridged that to the microbubble by attaching it to the strep-avidin. Our initial studies were in vitro, in which we took cultured endothelial cells and mounted them in the interior of a parallel plate perfusion chamber that had inlet and outlet ports through which we could perfuse the microbubbles using well-defined wall shear rates, because the fluid dynamic properties of this chamber are well characterized. And then we could mount this chamber on an inverted microscope and visualize the interactions of the microbubbles with the endothelial cells. This is some of our initial work, and we took fluorescently labeled microbubbles, shown here in green, and attached either the anti-ICAM antibody to the surface or a control non-specific isotype IgG. These are micrographs of normal endothelial cells and activated endothelial cells that are lining that parallel plate perfusion chamber that I just showed. As you can see here, activated or inflamed endothelial cells that overexpress ICAM1 bind these microbubbles, shown here as green dots, in large quantities, whereas normal endothelial cells minimally bind the microbubbles, and the nonspecific control IgG microbubbles do not adhere to the cells under either condition. So this showed proof of concept that these targeted microbubbles could bind to biological surfaces overexpressing the target. We then took this to an in vivo model to determine whether these binding events could be visualized. So we took a rat heart transplant model of acute rejection, which is associated with very fulminant overexpression of ICAM1. This is an abdominal heterotopic heart transplant in which the heart is planted into the abdomen of another rat. So the control group isograph with no rejection is a Lewis to Lewis strain heart transplant, and the acute rejection group is a Brown Norway to a Lewis strain heart transplant. This shows some images that we obtained in the short axis view of using ultraharmonic imaging. Shown here on the left are delayed images after injection of microbubbles bearing ICAM on the surface, or on the right, microbubbles bearing nonspecific IgG. As you can see, the rejection heart demonstrated strong persistent signal from microbubbles that were directed against ICAM1, likely due to adhesion of ICAM1 to the microbubbles bearing ICAM1 to the endothelium, whereas the control conditions did not show strong persistent signal. As you can see here, the rejecting heart is associated with very strong infiltration of inflammatory cells compared to the control, and then immunohistochemical staining shows strong ICAM staining. So this is an example of how this technology can be used for the non-invasive detection of acute organ rejection. Other groups have used similar strategies in which leukocyte adhesion molecules were targeted. In this case, this is from Dr. Kaufman in Dr. Lindner's lab, using a VCAM-targeted microbubble. VCAM is overexpressed in early atherosclerotic lesions of ApoE deficient mice, and this is imaging, high-frequency imaging of the aorta in these mice, showing a strong signal of persistent contrast enhancement from the VCAM-targeted bubbles not seen under control conditions. So this is an example of early atherosclerosis detected using molecular imaging with ultrasound. I'm now going to talk a little bit about the potential role of molecular imaging in the detection of ischemic memory. The clinical rationale for this is shown on this slide. So the challenge of, it's very challenging to make the diagnosis of acute coronary syndromes in the emergency department. So the scenario is a patient that presents, for example, to the emergency room with chest pain that is maybe a little bit atypical of an acute coronary syndrome, or it's resolved by the time they present to the emergency room. So they say, "Doctor, I had chest pain earlier this morning. I didn't worry about it until now, a few hours later." And so the challenge is to determine whether this is coming from the heart or whether it's non-cardiac in etiology. The ECG, the EKG, is often non-diagnostic, and the typical serum cardiac biomarkers are not sensitive for detecting transient ischemia in the absence of infarction, and it takes several hours to become positive. So in the acute setting, this is not that helpful. Segmental wall motion on echocardiography may be normal even though there has been prior ischemia, if the ischemia has resolved. And importantly, in patients who've had prior myocardial infarction, abnormal wall motion may not distinguish between an old event versus a new ischemic insult, which is what you want to detect. So there are molecular signatures, however, of true myocardial ischemia, which, if detected, can help make the diagnosis as to whether chest pain is due to cardiac ischemia or a non-cardiac cause. And in particular, P-Selectin is overexpressed in ischemia reperfusion. This is from a model of ischemia reperfusion, and P-Selectin overexpression was quantified on histology. And as you can see here, upon reperfusion, there's a dramatic overexpression of P-Selectin due to release of preformed P-Selectin from the cytoplasm of the endothelial cells. So what we decided to do was to make a bubble that would be targeted to bind to P-Selectin using Sialyl Lewis X as the targeting ligand. Sialyl Lewis X is the naturally occurring tetrasaccharide ligand for P and E selectin, and it has some advantages in that it's got low molecular weight, it can be synthesized, it's strongly conserved between species, and we're able to also create a control saccharide, which is Lewis X, which does not adhere to selectins. So this is a intravital microscopic study showing adhesion of Sialyl Lewis X microbubbles to inflamed endothelium. So this is a schematic of a microbubble bearing Sialyl Lewis X. And basically here, this is TNF alpha inflamed venules in rat cremaster muscle. And as you can see here, there is adhesion, these bright dots of fluorescent microbubbles labeled with Sialyl Lewis X to the inflamed endothelium. This is, these are the control conditions showing non-inflamed endothelium with minimal adhesion of bubbles, which are pseudo-colorized here in red, and this is inflamed endothelium with the adhesion of the Sialyl Lewis X microbubbles. So we proved the concept that Sialyl Lewis X microbubbles can adhere to inflamed endothelium. So then the question is, can this be imaged in a scenario similar to what I mentioned, with a patient presenting with chest pain to the emergency room? So what we did was we took a rat model of myocardial ischemia reperfusion. So we took a rat and occluded the left coronary artery to create ischemia. This is a regular myocardial perfusion image showing a risk area during coronary occlusion, and during reperfusion there is reflow to the previously ischemic area. This is non-targeted microbubble imaging. So this is an example of a patient with transient ischemia in the absence of infarction. After injection of microbubbles bearing Sialyl Lewis X or targeted to P-Selectin, you can see that there is persistent contrast enhancement in the area that used to be ischemic, indicating that the tissue remembers or has memory for the prior ischemic event by virtue of overexpression of P-Selectin to which the microbubbles are binding. whereas the control microbubbles do not have any persistent contrast enhancement. So not only does the technique show the presence of primary myocardial ischemia, but it can also show you the extent of myocardium at risk. So in this particular case, this is a large area at risk. And so if a patient had this type of image, you would know that not only had they been ischemic, but a large portion of their heart was at risk. I'm just going to finish up now with some work on the use of ultrasound molecular imaging to detect angiogenesis. The clinical rationale for angiogenesis imaging is shown on this slide. Clinical trials in therapeutic angiogenesis have been disappointing in that they have not shown the same robust results that were demonstrated in preclinical studies using the traditional clinical endpoints. It's been argued that perhaps one reason is that the clinical methods currently in use are not sensitive for detecting neovascularization, and patients may differ in their individual responses to angiogenesis treatment. Furthermore, neovascularization involves complex molecular events, in vivo detection of which may demonstrate important molecular responses and identify patients more likely to respond to angiogenic strategies. So the goal here would be to identify molecular markers of angiogenesis as a surrogate for neovascularization. In collaboration with colleagues at the University of Pittsburgh, who've identified a tripeptide sequence, we developed a microbubble that appears to bind specifically to tumor endothelium. This tripeptide was found using a peptide display library panned against mouse squamous cell carcinoma-derived endothelial cells. And this is after intravenous injection of fluorescently labeled RRL, the tripeptide. And as you can see here, there is perivascular location in the sarcoma of a mouse, and these are cultured cells that are stained with a fluorescent RRL, and as you can see, there is adhesion of the RRL to tumor-derived endothelial cells, but not to control cells. So what we did was we put this tripeptide RRL on a microbubble and injected it intravenously into a variety of tumor models in mice, one bearing clone C sarcoma and the other PC3 human prostate cancer. And we intravenously injected microbubbles bearing RRL or a control microbubble bearing glycine tripeptide sequence. As you can see here, the tumor shows strong persistent contrast enhancement after injection of the microbubbles bearing the tripeptide sequence. The specific for angiogenic tumor endothelium, which is not seen under control conditions. And for control tissue, we use myocardium, showing that there is no significant adhesion of either microbubble type to normal tissue. So this potentially can be used to detect tumor angiogenesis and or response of tumors to anti-angiogenic treatments. Dr. Howard Leong Poi also has described a method for detecting angiogenesis, targeting integrins that are overexpressed during neovascularization. And this is a model of rat hind limb ischemia. And as you can see here, this is after treatment with FGF2. This is the ischemic limb. As you can see that there's intense angiogenesis after targeted imaging of a treated ischemic limb, showing more intense angiogenesis compared to the non-treated limb. So an example here of how molecular imaging of angiogenesis can be used to follow therapeutic responses. So in summary, ultrasound molecular imaging is possible using microbubbles that can be targeted to bind to function-specific endothelial epitopes. The pathophysiologic states that can be ultrasonically imaged in vivo that have been shown in terms of proof of concept include inflammatory states such as heart transplant rejection, ischemic memory, and atherosclerosis, as well as neovascularization. There are strong advantages of ultrasound for molecular imaging compared to other molecular imaging strategies. For example, there's relatively simple instrumentation, and it's portable and can be used at the bedside, unlike some of the more complex nuclear magnetic or isotope-based strategies. There is no extravasation of the contrast agents, so that we're able to image exclusive endothelial targets. This is not a hotspot imaging technique, and we don't have the problem of extracardiac uptake of the probes, because we can do simultaneous anatomic imaging as well as molecular imaging, so that we can get registration of our molecular signals superimposed on the anatomic information, which is not possible using nuclear methods. The future work that remains for molecular imaging with ultrasound includes the need to improve the signal-to-noise ratio using various strategies, such as increasing microbubble binding using multi-targeting strategies or better targeting ligands. Importantly, imaging systems also need to be optimized to detect microbubble binding, perhaps using approaches that are more sensitive to detect signals that are specific to bound as opposed to circulating microbubbles. I think it would be important to identify non-antibody targeting ligands so that the immunogenicity associated with antibodies can be avoided. And importantly, we really need to make efforts to translate molecular imaging into the clinical arena. Another important area of future work is to use these targeting strategies to implement microbubble-mediated ultrasound therapeutics, such as drug and gene delivery and other strategies for treatment using the unique behavior of microbubbles when presented in an ultrasound field. I'd like to just acknowledge the people in the Center for Ultrasound and Molecular Imaging and Therapeutics, both past and present, who have been involved in the data that I presented in this talk, as well as our funding agencies.